Okay, over to you, Ewan.
Righto. Well, hello everyone and welcome to this webinar can you put up a slide please, Nick? I'm Ewan Macdonald, University of Glasgow, and I chair the SOM Long COVID Multidisciplinary Committee. And I'm also a member of the committees in Scotland and the Department of Health committees in Scotland and England. Nick, are you showing my slides, please? Yeah, okay, great, thanks. That's good. Okay, so this is about return to work support and what works. Now, long COVID has been with us for quite a long time, just about as long as the beginning of the pandemic, and there are still many unanswered questions, and one of them is what works? And there's a huge divergence of approaches being taken, not only in the UK, but elsewhere. And that's what we're going to explore this afternoon. Next slide, please. So just to remind you, there's a large number of cases of globally of COVID, a lot of deaths, 6 million is a big underestimate. The UK long COVID is estimated to affect 1.3 million people, which that would mean in Scotland, it's about 110,000. And the definition of long COVID for the purposes of this meeting is symptoms more than 4 weeks. Next slide, please. So because I do clinical work, I saw very early on in the pandemic, people with very serious damage due to COVID. So I've never been somebody who's thought that COVID is a mild illness and long COVID is just a bit of post-viral fatigue. This lady who's given permission me to talk about her, very fit and active and now severely disabled. I'm not going to read out the slide because of time. And as a support worker in social care, now completely unfit, and she's lost her job. Next slide. This is a friend of mine whose partner returned from a place called Wuhan in November 2019. When I saw him in December, visiting me in his house, he was full of the cold, sneezing, coughing violently. Kept my distance. It turns out that he had COVID, and he didn't go to his doctor because he hadn't been to see his doctor for 10 years. Thought he could get it over because he's a strong man. Exercise tolerance 40% of normal. Eventually investigated, found to have lung scarring and a myocardial infarct, and still now operating about 60 to 70% of his previous exercise tolerance, which was considerable. Next slide, please. So thanks to Clare Rayner for these slides. These slides, next two slides, have been put together by a long COVID support group very early on in the whole process, and where a lot of the very useful information came from, whereas while the medical profession was rather either preoccupied with acute COVID or a bit dubious about the vague symptoms of long COVID. Long COVID, as we know, next slide, can affect any part of the body. These slides can be made available if people wish. Any part of the body, and can be very significant. So it's a very complex phenomenon, long COVID. Next slide, please. Probably it's a multi-system disease, primarily a disease of blood vessels, causing an endotheliitis. Some people don't have a diagnosis of COVID-19. It was a new syndrome. It wasn't recognized initially. If it doesn't fit the normal paradigms, people don't recognize it or think it's not there. Often people have had inadequate medical care because acute COVID has been dominating. There's generally a lack of good rehabilitation facilities, certainly in the UK, and long-term absence leading to potential job loss, which is why this is such importance and of interest to the Society of Occupational Medicine and my discipline. Next slide, please. Now, what's this to do with long COVID? Well, this is 2014. This is showing you the population of the UK and how they fall out of work between 50 and 64. And that's a subject of study for me and people like Lodi, who's speaking after me. So there's a lot of people fall out of work for one reason or another between 50 and 64. Next slide, please. This is really related to multimorbidity, because as we age, we get medical conditions anyway. And I was very naughty and unscientific, and if I show you the next slide, you can see that where people are falling out of work is where people are getting more and more medical conditions, often quite mild. Next slide. So the big issue we've got, and I'm giving in this brief introduction, that long COVID is adding to an existing burden of multimorbidity in an aging workforce. Now, I'm not saying people who've got long COVID are aging particularly. In fact, lots of my good friends are long COVID sufferers, and I wouldn't dare say they're all aging. But long COVID is the sting in the tail of this pandemic. Long COVID is the challenge we've got, and it's not getting a huge amount of health resources, but it's definitely the sting in the tail. If people fall out of work due to long COVID, they'll be the same as other people who fall out of work. It will increase job loss in aging workers. Losing your job as an aging worker prematurely reduces your life expectancy. And long COVID will add to that too, unless we're very proactive. So that's my introductory comments, how I perceive it. I'm now just going to go straight on to welcome Lesley Godderis. Well, Lesley is probably one of the most distinguished occupational health specialists globally, actually. He's a professor at the Centre for Environment and Health at the University of Leuven. And there he has 4 postdoctoral staff, 8 PhD students, 3 laboratory co-workers. I'm sure it's actually got more than that now. And he also combines academic work with clinical work, in that he's the director of IDEWE, one of the largest occupational health services in Belgium. Belgium has virtually universal occupational health. And there he has 27 co-workers, including 19 researchers. So he's combining research and practice. So, Lesley, thank you so much for being willing to speak to us today. Really looking forward to what you have to say in your terms of your review of long COVID. And over to you.
Thanks a lot, Ewan, for this very nice words and a kind introduction. I hope you can all hear me well and that you also can see the slides.
Yeah.
I think I just need to change like this, correct? Better view on the slides?
Yeah.
Okay, thanks a lot, Nick. So yes, I will be talking about long COVID and return to work. We've done some research on it, and I'm happy to share with you the most recent updates on this. Before I start, I would like to share you this complex graph, but it's quite interesting because it shows the incidence of COVID-19 confirmed by PCR in individuals. And these data in Belgium are gathered in a public health agency. And we managed to link these data with the sector that people are working in. And so every 2 weeks since the beginning of September 2020, we report on a 2-weekly basis the incidences according to the sector that people are working in. And you see here the different waves that are quite similar to the pattern you've had in the UK as well. But I show you this slide to show that there are quite some differences between sectors. Obviously, the healthcare sector and education sector report the highest incidences, but also that these incidences change over time and according to the phase we were in the pandemic. The last reason why I'm showing this graph is also that it's clear that a lot of healthy individuals, people working at the workplace, got COVID-19, and so potentially they could suffer from long COVID if not well recovered. So it could have a big impact on the ability to work of many of people. If you look at the 14-day incidence, I forgot to mention you this is reported per 100,000 employees in Belgium. So it goes about a very big part of the Belgian working population. This is a bit the pattern of a COVID-19. You see people get infected with SARS-CoV-2 virus, then gradually it can be picked up by PCR, and symptoms appear. They last for 2, 3, 4 weeks, and then gradually decrease. And more or less, when the PCR becomes negative, some common symptoms like fatigue, dyspnea, and other complaints we know all well of COVID-19 are disappearing. Ewan already mentioned about the importance of the definition of long COVID, and there are quite some differences, as I will show you. But here, it's not illogical to focus on the remaining symptoms that last longer than 4 weeks. And then traditionally one makes a distinction between after this phase of the acute COVID-19, after 4 weeks, one talks about post-acute COVID-19, and there you see also a division for the first 3 months. One talks about subacute or ongoing COVID-19, so which can be explained by remaining effects of the virus itself. And after the 12 weeks or 3 months, we talk about chronic or post-COVID-19, which could be more a consequence of mechanisms in response to the COVID-19 infection. This is, there are several definitions, as I've mentioned before, and that plays a big role also if we are looking at the data on the number of the percentage of workers that still suffer from these symptoms after COVID-19. And second, if you want to do studies on sickness, absenteeism, and sick leave after long COVID, we also need to take into account that according to the study we are looking at, the definition can differ. Here I present you the NICE definitions, which is one of the most referenced definitions, and NICE defined long COVID as symptoms that continue or develop after acute COVID-19, including ongoing symptomatic COVID-19 symptoms then from 4 to 12 weeks, or post-COVID, as I mentioned earlier, that refer to symptoms taking longer than 12 weeks. This is the NICE definition, and also the WHO has made a definition. The link you find here below the slide, where you can find more information about this definition, but also referring here to a post-COVID-19 condition that usually lasts 3 months from the onset of COVID-19. And that cannot be, so that lasts at least 2 months, that cannot be explained by an alternative diagnosis. And maybe that's also something already important to mention here. You might wonder why at least 2 months while the period can cover 3 months is, as I suggested already from the NICE definition as well, is that symptoms can appear also in patients that did not report many symptoms while being infected with the virus. The symptoms, the common symptoms include fatigue, shortness of breath, cognitive dysfunction, which have an impact on everyday functioning and consequently as well on the work ability. As I mentioned, the symptoms may be new onset, so that's also important not to miss as occupational health physicians. And a last important point for us is that symptoms may fluctuate over time with also a risk of relapse. On the prevalence of long COVID, quite some studies have been published. Here in Belgium, it performed a study by the KCE that summarized these data in this interesting plot. So what you are seeing here is the long COVID prevalence and percentages on the y-axis, and on the x-axis then you see the time since onset. And in these studies, the prevalence of long COVID is studied. And in this graph, the studies were grouped according to the initial treatment of the patients. So the blue studies refer to studies including only non-hospitalized patients. The green triangles refer to studies including mostly non-hospitalized patients. And the red square refers to studies including mostly hospitalized patients. And as you can appreciate visually, you can see that studies, or you could conclude that studies including mostly hospitalized patients seem, in this group of patients, there the prevalence seems to be higher. This is a similar plot, again with the same categorization, which confirms a bit what I've just mentioned, and gives more concise information about the prevalence. And you see it ranges between 20% and 30% according to the period we are looking at, and remarkably the prevalence remains quite high in these studies even after 6 months. Hospitalization seems to be one of the risk factors for long COVID, but as I indicated earlier, long COVID can also occur in patients with mild symptoms, but yeah, the severity of symptoms can thus play a role, but also whether or not several symptoms are present during the acute phase seem to increase the risk as well. So if you have fatigue combined with dyspnea and other symptoms, well, it's not only the severity, but also the number of symptoms the patients had during the acute phase that seems to increase the risk. If we look at the ages, basically all ages have risk, but it's mainly people aged between 35 and 69 years old seems to have the higher risk. If we look at children, the percentages given in most studies range between 2 and 7% after 3 months. Also, there's an influence of gender, more women than men. And there's also some more and more indication about the importance of comorbidities. So it might be that long COVID could be explained by a worsening of existing health conditions. The next slide, I give you an overview of the most reported symptoms of long COVID. I will take you from the right till the left. And the upper right, you see headache, but you also see the wide range between 9 and 91%. So it's a very wide range. So you can imagine that according to the definition and the way headache was surveyed, that has a big influence on the reported prevalence. So also mental health problems and cognitive dysfunction is quite often reported. You see metabolic symptoms, diabetes, high cholesterol, problems of the kidney, also the loss of taste and smell, which is quite known, general symptoms like fatigue and muscle weakness and pain. The lung obviously is also infected with cough and breathlessness, gastrointestinal symptoms, constipation and diarrhea, and also heart symptoms like chest pain. So quite a range of symptoms. There's still ongoing research about possible mechanisms leading to long COVID. I already made reference to the potential role of hospitalization. And that's also why a lot of researchers think there might be a link with the post-intensive care syndrome, which is also characterized by an impairment of muscles and nerves that may develop during the course of an ICU stay and persist for quite a long time. Also, these patients report mental health problems, including anxiety and depression, and also cognitive disorders, including memory or concentration disorders, are reported within these symptoms. So this also, of course, you see quite some similarities and overlap in symptoms. If we then dig further into the possible mechanisms, you see here that according to the organ system and function we are looking at, that different potential mechanisms are being brought forward. If you look at the neurological and psychological disorder, there's some indication about inflammation. It also autoimmune factors can play a role, and also the residual infection. So that's still a direct effect of the virus. And there could also be an involvement of the gut-brain axis. So quite some different mechanisms that can explain the neurological and psychological symptoms. For senses, it seems more like but inflammation plays a major role there. The same also for fatigue and pain, but also there the lymphatic and lymphatic system congestion can play a role. Gastrointestinal, also combination of inflammation and autonomous nerve system dysfunction. And finally, for the cardiovascular symptoms, one thinks about the endothelial dysfunction with an activation of coagulation and cardiomyocytes invasion. The reason why I show you this is that long COVID is a collection of symptoms. So if we want to treat long COVID, we might need adapt our treatment depending on the symptoms presented by the patient, and also take into account that different mechanisms can play a role. If you want to bring it a bit together, here for the cardiorespiratory symptoms, you see that both cardiovascular system and pulmonary system that are infected by the virus, there we see some indication of the dysfunction of the endothelial cell leading to cardiomyocyte injuries, an impact on autonomous nerve system injury, and also lung fibrotic remodeling and pulmonary vasculature damages. So it all can be explained by inflammation leading to the symptoms on the right of the slide. The other second big, besides the inflammation, the second big hypothesis is about neurological mechanisms, but also there you can see a link can be made with inflammation, which can lead then to neuroinflammation, and finally leads to neuronal damage and neuronal dysfunction that can explain then more the neurocognitive disorders and the fatigue. So quite a range of different mechanisms that need to take into account. In our center, we are also following up long COVID patients in collaboration with the pneumology clinic at UZ Leuven. These are the endpoints we are looking at. And so we are also looking not only try to elucidate the underlying mechanisms, but also try to see the impact on daily life functioning. At the moment, yeah, we are still recruiting, so it's too early for me now to give you more information about the results. But yeah, what I indicated already, if we talk about the management, it's clear that interdisciplinary management is important. If I understood well, in the UK, you have clinics where different disciplines work together to treat the long COVID-19 patients. In Belgium, we do not have this specialized clinic, but we use more a tiered approach. Normally, the general practitioner is in the lead, and depending on the severity and the complexity of the symptoms, the general practitioner can refer to some hospitals in which a multidisciplinary approach is being used for the management of these patients. So, but this is all at the moment being set up, and the protocols are being developed and implemented. For us, occupational health physicians, we do play a role in return to work processes, and that's the last part of my presentation for you. So I would stress that long COVID has, of course, an impact on the daily function, including work capacity, and might hinder an effective return to work. We also see that mental health does play a role, and also there's an impact on social life. If we look at the studies in which workers are asked to report about those symptoms they perceive that have the biggest impact on their work capacity, then you see that mostly 3 categories of symptoms are being reported. Memory problems and cognitive dysfunction. Second, and that might be a bit surprising, is the loss of taste and smell. And of course, as you can expect, also the fatigue is most frequently reported within the working population as hindering for work life. We performed a systematic review funded by the HSE. The report you can download from the link you see here on this slide. So we collected the evidence till March 8, 2021. But for today's presentation, I have updated this report and included new studies. If I rerun the same syntax, then at the moment, when we did the first systematic review, so before March 8th, then we had more or less 2,200 hits, if I remember well. The last time I did it, which was a month ago, we identified 6,161 records. After cleaning up the duplicates and the inclusion and excluding criteria, after application of these criteria, we could include in total 25 studies now. In the report of HSE, we had 7 studies. So it's clear that more studies are coming out at the moment. I just give you two examples of studies. It gives also a bit an appreciation of the type of studies we find at the moment. And so most of the studies, a lot of studies are web-based studies, and that's important to mention because if you do studies through social media, you can imagine that you attract a certain public and that you might be able to reach out easier to certain patient groups, but that might also lead to an over interpretation and higher prevalences. In these studies, for example, 88% of the participants still experienced cognitive dysfunction and memory loss, which had a great impact on their work. See also quite big numbers, 86% of the respondents felt mildly to severely symptoms and were unable to work. Fortunately, and at that time, I think that's an important point. During the pandemic, a lot of people among us worked remotely, working from home, which gave you a lot of autonomy on how you were during the day. You did not have to commute either. So telework certainly could help people to remain at work and to get back to work. And also, as I mentioned earlier, relapses can occur, and there seems to be a link with both physical and mental stressors at work. And in that sense, it's also interesting, and in our study, the study also presented, we are also following up a group of people suffering from ME and chronic fatigue syndrome, and also there you see that the post-exertional fatigue of exhaustion is also an important trigger of the exhaustion reported by this group of patients. So also here, maybe that means that it's good to stimulate people to pick up physical activity, but it's important to assess whether they are also suffering from symptoms like the post-exertional fatigue, because if that's the case, then we need to find a balance between the workload, the physical load that somebody can handle without having negative symptoms afterwards. So that it's important to set and decide on the workload. This is another type of study, again here through a Facebook support group, and I think most of the symptoms here we have mentioned already. But even you see, even after 6 months, quite important percentages still reported effects that had an impact on their work capacity. So the limitations so far, most of the studies we found, return to work was not the main objective of outcome of the study. So that's an important limitation. Social media is a powerful tool to collect data, but also has its limitation. We also need to be aware that people from a lower socioeconomic background are difficult to reach. And also, as I indicated earlier, there are different definitions of long COVID. What I also wanted to share, this is,
you got a couple of minutes, really.
Yeah, I'm wrapping up. Yes, thank you. This study was performed in 1,320 patients here in Belgium. And actually, they were asked, what are your needs? And actually here, you see that most people feel the need or report as a need, and 1 on 3 says, okay, we want to talk to health professionals, and we want to get information. They also want to talk to other long COVID patients, so kind of peer groups are very useful. And also the fact that people can talk themselves about their problems seems to be a clear need. So I think that's also quite a remarkable outcome of the actual most frequently reported needs by the patients. Understanding, being able to talk to a health professional, and having contact with peers. So that's certainly something we can set up within occupational health as well when it concerns return to work. In fact, if we then look a bit at the factors that need to take into account when we consider return to work, I would classify them in 4 big categories. The first category is on functioning. What's the perception of the individual, the patient, on their health, and what are the expectations on return to work? So that's the first category. The second category is also the stress. As I indicated, it can lead to the onset of symptoms. Also the work-related factors to play a role, because physical loads is important, I think, but also needs to be followed up to avoid post-exertional exhaustion. But also here you see that mainly psychosocial support factors, good relationship with colleagues does play a role. And we also have person-related factors, just like fear of getting back and fear of colleagues. So my proposal here is let's help people to get back to work, do this person-centered, so adapted care, so a progressive, adapted, and appropriate return to work program is important and is an important part of the rehabilitation and the recovery of the patients. I think also an early contact with the employee by preference, very early in the first 2 months of absence is important. Maybe if occupational health physicians say, hey, I want to also participate and share in studies on this topic, you can take contact with us because we have established a European network on work and COVID. And so we are looking for occupational health physicians who want to participate in studies about the impact of COVID-19 on and long COVID on work and return to work. Here you see the contact information, so feel free to approach us, and I hopefully we can get in touch. These are my final conclusions, and with this slide I hand over to the chair of this session, and I'm happy to address any question if there would be any. Back to you.
Yeah, thanks very much, Lesley. So we've had a really good research coverage. Great project you did with HSC, and it's good to settle on that slide in terms of the conclusions, in terms of support to return to work. But we're moving quickly from the research side, what we've learned so far, to the employer perspective. And CIPD have done some great work with Joe Yarker on long COVID and the employer perspectives. I'm really pleased that we've got Rachel and Joe who've been involved in producing this report with the HR kind of community. It's great that they've got this long COVID perspective now, so congratulations on this work to run through employer perspectives on long COVID. And really, it's for people in the audience, take people to task if you see that they're not following this advice. So over to you, Rachel and Joe.
Hi everybody, really pleased to be here. Can everybody see my slides okay?
Yeah, that's perfect.
Not brilliant. Okay, well, absolutely fascinating to hear Lode with that research. Really, really interesting. And also Ewan's comments too. Really pleased to be here. So thank you for inviting myself and Joe. I'm really pleased to do this as a joint presentation with Joe, because it's Joe that's been carrying out the research for the CIPD to develop our report research, but also our guidance, because as Nick said, we really do want to shine a very sharp light on the importance of long COVID and why it's a really important workplace issue, that of course occupational health are at the centre of supporting people at work through that, but also we need much wider recognition and support from everybody in the workplace, organisations, employers, and also HR, who lead on a lot of organisations' health and wellbeing programmes, and also line managers as well, who have that day-to-day role in terms of supporting people. So that's our aim. This is a CIPD, just in case anybody isn't familiar with us. We're a professional body for HR and people development around the world, but mainly both based in the UK, and we have 160,000 members, again, mainly in the UK. So before introducing the research and the work that we're doing to raise awareness and improve support for people at work on long COVID, I just wanted to give some wider context to the pandemic and HR and HR's role, because I think this is directly relevant to how we improve that support in workplaces. And of course, over the last 2 years, organisations have been absolutely thrown into crisis, really, coping with the pandemic and the crisis as well. And HR have been playing a central role in many organisations' response. Yes, of course, stepping up to protect people's health, wellbeing and safety, but also all the other huge people challenges, lots of new ways of working, of course, the mass working from home move, and then hybrid working now, and of course the return to workplaces in some situations, managing sickness absence, of course, staffing shortages, so many health and wellbeing related issues. And on the right hand side, I've just put a little image of our annual Health and Wellbeing at Work survey report. We've been running this survey now through the eyes of HR professionals for 20 years, just to get a barometer on how HR are supporting people's health and wellbeing, managing absence and all those other issues. And we know from that research last year and this year, we're just about to publish this year's report, that organisations have been really understandably very, very concerned about people's health and wellbeing, including their mental health, and most have been taking additional steps to protect people's health and wellbeing. And the sample size, I mean, it's very different research to the research that Lode was talking about. This is practitioner research. It's about HR professionals and how they support health and wellbeing, but it covers over 800 organisations collectively. That's almost 4.5 million employees. So that's quite a significant sample of the UK labour market. But what the research also shows last year and this year, and this is very relevant to how we improve support and understanding, awareness and so on around people experiencing long COVID, there is a really big expectation on line managers to support people day to day. Of course, not in any medical way. Obviously, occupational health are the experts there. But in terms of spotting early warning signs of ill health generally, having sensitive conversations with people who might need support, signposting to that crucial expert help like occupational health, making helpful, reasonable adjustments, and not necessarily just if somebody meets that high bar of having a disability. We know that long COVID doesn't necessarily fall into that legal category yet, so therefore it's very important that line managers are encouraged to make adjustments for people if they've got any symptoms, regardless of whether that is a disability. But we also know from our research, and this goes back years and years and years, that there's a really big gap in terms of expectation on managers on the one hand, and the investment that employers make in their training to make sure they understand what their role is, how they go about it, the guidance that they're given, the capability, the education they have, and the confidence and just the time as well to properly support people's health and well-being and have those conversations. There's a really big gap. So this does kind of lay the ground for how we talk about improving support around long COVID, because the question we've got to ask ourselves is, how ready are organisations to support people with a health condition or a disability, including long COVID? And what we know from our research is that too few people with a disability or health condition were already receiving the support, flexibility, access to more specialist help and so on that they need to remain in work and, well, remain in work, let alone, and carry on working, manage their work alongside their symptoms, let alone thrive. And that's what we really need to change. And that's, and of course, long COVID requires specific understanding beyond even lots of health conditions, you know, different disabilities and so on, where, you know, we need much more understanding and so on. But I think there's still too much misunderstanding about long COVID, especially when we see the narrative changing now in the media that we're through the pandemic possibly, and, you know, no need to isolate, and, you know, so the narrative's changing, but long COVID is still very much with us and will be with us. So it needs specific attention. But moving on to my second bullet point, in terms of how ready and capable are organisations to really support people with long COVID? Well, our research shows that most organisations, they experience challenges. They're not confident enough. They don't have the capability to support people with a disability or health condition. And when we said, well, what are the obstacles that you experience, it is a lot around developing that knowledge and confidence and so on of line managers who are that day-to-day support. And it's not surprising if you look at the third bullet, because only a quarter of organisations that we surveyed, quite a big sample, as I said, actually provide line managers with any training or guidance or support so that they can support people within the limitations of their role in terms of long-term health conditions. So there's a really big need there for more investment in this area. And then coming on to long COVID, in the report that we'll publish in about 3 weeks, the health and wellbeing report, we had a lot of questions around specifically COVID and long COVID. And in terms of prevalence, I mean, this is quite a different sort of perspective on prevalence to low days, but nearly half of employers, 46%, said that they had employees over the past year who had long COVID. And this is quite significant. 1 in 4, so around a quarter of employers, now include long COVID among their top causes of long-term sickness absence. So in terms of prevalence, in terms of impact, this is a really significant issue that HR and employers need to be aware of. And this is why we have been, as Nick said, over the past year or so, really been having a strong focus on calling for more awareness on the part of employers, but specifically our HR membership, really calling out the need for organisations to urgently review their health and wellbeing frameworks, ensure they are providing effective support for those with long COVID. And of course, at the centre of that, and I think this came through really strongly in Loday's presentation, recognising that each individual's experience is different. So they need that individualised support. Now, encouragingly, of those employers in our survey who said, yes, we've had employees who've experienced long COVID, most are taking steps to support people and taking a whole range of steps. The top 3 here are offering occupational health assessments, that's good. Tailoring support to individual need, again, good. promoting flexible working. I think flexibility is an important aspect of how people can carry on working where they're able to. And then stepping up support. This is the theme of what we're encouraging organisations to do. But to do that in a really evidence-based way, we supported the research that Dr. Jo Yarker, who's going to talk now, to carry on, that she'd already started with Sheffield University, because we knew we needed deeper insights in the workplace based on the experiences of employees to really inform what kind of practical guidance we could send out to our members and organisations as well. So the research that we carried out, that Jo will talk about, as well as looking at the experiences of employees, and really big call out here to the long COVID support group and Lesley Macniven, who was also going to speak. Also, we had the input of HR managers, occupational health and other health professionals. There's the research report, and then the week after next, we're publishing 4 guides for managers, for HR, for employees with long COVID, and also for colleagues, because we need a whole ecosystem of support around this. And of course, involving occupational health within that as well. So final slide, I just want to flag our website, other guidance that we've got that's relevant, that could be of support. And we also are building our long COVID hub, where we also signpost to SOMS, practical guidance too, and other resources. So do visit our website. Thank you. I'm going to hand over to Jo now. Thank you.
Great. Thank you so much. So I'm just going to very briefly talk through some of the key findings and also position the research so you understand where it came from and where this practical approach came from. So for a number of years, we've been looking at what supports return to work and what helps people stay in work, particularly with a focus on mental ill health, but also looking at other chronic conditions and long-term conditions, such as working through cancer treatment, working with musculoskeletal pain. And we were delighted to get some funding from Sheffield University to see whether this approach, using an igloo approach, which I'll talk about in a second, could really help us identify some practical solutions and provide a framework for a conversation that people with long COVID could have with their colleagues, with their line manager, with HR. Because as we know, there's so much more we need to understand about symptoms, about what we can do to support people in terms of treatment and therapeutic treatments, but also on the ground in the workplace, when you're talking to your colleague or your manager about what you might need. It's very hard to do that and think about what might be useful when you've never been in this position and when you don't necessarily know what's going to be helpful. So what we wanted to do was explore from others what has been helpful and take a resource-based approach. And this really looks at a whole system approach to employee wellbeing. So rather than thinking you as an individual who's feeling unwell may benefit from X, Y, and Z therapies or treatments, it's thinking everybody has a role to play. And it draws from Hopfield's conservation of resources theory, with this idea that we like to gather resources. And if we can think of building many, many different resources that we can draw from as an individual who is trying to get back to work or sustain work, then we can identify resource gaps and also build ourselves this protective shield, which is how we've been using it in practice. And it really helps people understand what their role is in protecting individuals and enabling them to thrive. And so we have an evidence review. We interviewed 14 workers who had been on a return to work and staying at work journey in very many different ways. As we can see from Lode's presentation and also before from Ewan, and I'm sure many of you have experience of people with various functionality. Everyone's experience is different, but what we could understand is what are the key barriers and also what are the key facilitators? What are those things that are common in supporting people to stay at work and work well and safely? And we were delighted to then build on that with funding from the CIPD to conduct roundtables with 43 professionals across different health specialisms with HR input, to really understand what is it that is practically making a difference to people's ability to work. And so the central premise comes down to the fact that we can't do it all on our own. We need to have others in our environment to be able to support us to do, to look after ourselves and also to work well. So on the next slide, I'm going to race through the different aspects, and you can find these all in the report in much more detail with the barriers and the resources. And as Rachel was saying, guidance that will help to, I suppose, look at practical solutions that you can put into place. But what we saw at an individual level was this ability to come to terms with the reduced functioning, and not being able, not pushing yourself through like you did before was one of the key things that differentiated those people that were returning and able to stay at work. So many people returning to work and then falling out, or falling, that's not a word I like to use, but having to take themselves out of work because they weren't able to cope with the demands that were being placed on them. And so coming to terms with reduced functioning and then pacing themselves was very much key, and perhaps resetting career expectations for the time being until more was understood about the way that their condition was affecting them and the fluctuation of that condition as well. Being open about the symptoms of work and the impact on work functionality. And even though this was hard, those people who said that they'd built up the courage to talk about it with colleagues at work or with their line manager really did benefit from that. And then prioritizing self-care, really making sure that they blocked in time to do the things that were good for them, to take that rest and recuperation so that they could really then store their energy to thrive at work. And then being proactive in terms of managing the team mental health at the group level was absolutely key. Having colleagues that would understand what the potential impact was and how it might impact people. I'm seeing we're racing through slides here. So with the group level, just thinking about what our colleagues can do to really support us. So having colleagues that feel they can step in to help with particularly difficult tasks, but also treating people in the same way that they were treated before. So not as somebody who's damaged or broken, but talking to them at the same tone, same level as they would do before. At the line manager level, we saw a whole range of different things that a line manager can do. So on the next slide, we can see that people who worked well were those that had a line manager who took time to understand what long COVID was and how it impacted people at work. They were able to work flexibly and extend a phased return period so that it wasn't the traditional 4 weeks, which we know, so many of us know is actually a barrier for helping people return to work, because for many people with long COVID, that's just not viable. But having extended phased return periods over 6 months and allowing this test and learn approach where people can adjust tasks over time and take an individualized approach, so that when we're putting in adjustments, they're not necessarily adjustments that have to stay for the long term. They're things that we're trying, and then we're going to adapt as our condition may fluctuate over time. Also making sure we've got regular check-ins. So for those of you who work across return to work and across supporting employees, you'll see many of these things are familiar and useful for individuals managing a whole range of different chronic conditions. But these were the ones that were noted in our research. And then on this level of organisational elements, what we can see here is thinking about making sure that our policies and practices accommodate fluctuating conditions, that we have flexible work policies, that we have compassionate leave policies that don't penalise people on their return. Also, where the culture embraces psychological safety and thinks about this parity between mental health and physical health, because that is often where an organisational culture will open up discussions more safely around long COVID as well. We also want to make sure that we're taking a symptom-led rather than a diagnosis-led approach when we're looking at putting in place adjustments. So we know that the pathway to diagnosis is so long and so difficult for many, particularly when it comes to long COVID. So encouraging organisations to take a symptom-led approach. And then we also saw that many people were drawing from outside resources to sustain their work. And so on the next slide, you'll see that people were using occupational health services, long COVID clinics, vocational support, but increasingly in the UK, turning to employment advisors at IAP services as well as that real valuable support from support groups. So a whole range of things that we can draw from to build our knowledge and also identify our resources. And in terms of bringing that all together, then the next steps of what we need to do is really acknowledge that everybody has a role to play in supporting people back into work and staying at work with long COVID. So the employee themselves, the groups that they're working with, the line managers and the organisational professionals that are supporting them. And to do this, it means that we need to have easy access to increase knowledge, to increase skills and increase confidence in supporting people to return to and stay in work when they're managing long COVID, but also more broadly managing long-term conditions, because there are so many parallels, although yet many unique aspects when it comes to long COVID. And that's why we really need lots more research. I've seen the discussion thread, and there's certainly much more need to understand how people are staying at work and what's really supporting them. So here are a few links to the guidance. I hope that you'll find them useful, and things that if you're in a therapeutic role, you'll be able to share with people that you're supporting so that they can maybe share on to their organisations. And that way, hopefully, we'll be able to embrace multiple pathways to getting information out there. So thank you ever so much.
Thanks very much, Jo and Rachel. I mean, it's brilliant to see CIPD embracing this tissue. It's, you know, this is really the kind of the major difference I think that could happen actually is for HR people to understand this. And so thank you. Great work, Jo, too. I mean, the thread is interesting in terms of the chat, and Lesley Macniven, who's speaking later, has been great responding to people's concerns and thoughts. So thank you, Lesley, and keep putting those comments and questions on there. I think Clare Rayner too, who's going to be wrapping up at the end, has been responding. I know it's difficult and we haven't got kind of much time for chat, but hopefully there will be time for discussion at the end. But in the meantime, do put stuff in the chat, and I can see people are, you know, making connections. So that's great to see. So we're now doing a kind of whistle stop tour around the UK of hearing what's going on. There is a variation, sadly, in terms of what's offered. I think Ewan Macdonald might be a bit late. He's looking after his grandchildren, so he's coming back and probably will join at the end. So in terms of the running order, I might go Fauzia, Paul, and then Sarah, then Ewan. So Fauzia, I can see you're there, and Fauzia's been a great sort of contributor to the long COVID group that Ewan chairs. I'll put in the chat her background. She currently works full-time in the NHS as an occupational health physician, clinical medical lead for Derbyshire Long COVID Assessment Service, and really it's been lovely to see what she's been doing around the country. So I'm going to hand over to you, Fauzia. I think I made you co-chair, so welcome, and look forward to hearing from you. Oops, you're on mute. How are you doing with your sharing?
Trying to.
There we go. Great. Yeah, it's coming.
Perfect. So let me just put that on.
Perfect. Yeah, thank you.
Whoop. So I'm not sure why there's a side part to this. But hello everyone. Can everyone see the slides okay?
Yeah, we can see them. I mean, it's not on slideshow, but just go ahead if you can't make it slideshow.
No, we'll roll with it. Okay, so yeah. Hello everyone. My name is Fauzia, as Nick says, and thanks for attending today's session. I understand that there's huge variation between the services across the country. And over the next 10 minutes, I'll just highlight the service that we have got going on in Derbyshire Integrated Care System, otherwise known as Joined Up Care Derbyshire. So in terms of what we'll be covering, so I'll tell you a bit about case definitions in the context of what we accept in our service and current prevalence in England, and then move on to long COVID services landscape in general before talking about the service that we provide in Derbyshire. So in terms of case definition, so, you know, we're all familiar with acute COVID, ongoing symptomatic and post COVID-19 syndrome. In terms of Derbyshire services, we accept all referrals for COVID-19 persisting beyond 4 weeks. Where all health and social care employees are working in Derbyshire, they can self-refer to the staff service with no prior investigations due to the functional nature of the support that we provide. And the assessment service, however, does require the GP to carry out screening bloods and plus minus ECG, chest x-ray where clinically indicated to rule out common causes of the symptoms as part of their referral. So at the moment, we're basically bouncing back referrals that where these investigations haven't been done, and our CCG is supporting comms in kind of facilitating that. In terms of prevalence, COVID-19 infection survey is basically the largest survey of COVID-19 infections antibodies in the UK, and obviously what the ONS uses. In terms of weekly data, tells us that in England last week, over 2.6 million people had COVID-19 infection, which is basically 1 in 20. And in the context of other devolved nation, we're 1 in 20, whereas Wales is 1 in 25, Northern Ireland, Scotland, and 1 in 14 at the moment. And based on most recent data published on 3rd of March by the ONS, there's estimated 1.5 million people experiencing self-reporting long COVID symptoms. 22% had COVID less than 12 weeks ago, and sort of symptoms are ongoing, and 71% had COVID over 12 weeks ago, including 45% who had COVID over a year ago. And I hope you can appreciate from these figures the need to make our long COVID services or post-COVID services as fit for purpose. So some of the cohorts that these surveys have indicated that self-reported long COVID is greatest in, including people of working age, those living in deprived areas, those in health and social care, and those with activity-limiting health conditions such as obesity. And we've taken this into consideration when planning what sort of service we wanted to provide in Derbyshire within the assessment clinic. And we now have bought slots with Citizens Advice Bureau, trained bar therapists, and physiotherapists that work in our local council gyms to understand the needs of those with long COVID. And we've also been working with Livewell Derbyshire Weight Loss Management and created a sort of bespoke weight loss service for people with long COVID that we can also refer into. So long COVID services in general. So in terms of what NHS England want services to look like, based on suggestions from NICE, SIGN and the Royal College of GPs, this is a sort of blueprint that we should all be aiming for. And essentially it's, your GP refers you to the assessment service, and following the assessment, you get some self-management or supported self-management advice, or you get further advice through your MDT setting, or urgent conditions are picked up and sort of referred on where appropriate. And largely, this is what our service provides as well. In terms of the long COVID patient service, so this is the service in Derbyshire where all GPs can refer patients or people who are registered with the Derbyshire GP into. And this service kicked off in December 2020, and referrals into the service are accepted from Derbyshire GPs and our occupational health service once they've gone through the staff service, which I'll tell you about in a second. And referrals are only accepted with completed referral forms. And as I mentioned earlier, that's basically the form itself plus blood tests and any other investigations that the symptoms that they present with at the time indicate sort of warrant doing. And really, we are prioritising those who are under 16 in that service, pregnant patients and NHS staff. And currently, we are establishing paediatric provisions through our service. So that should become a lot more robust in the next few months. From December 2020 to 2021.
Fauzia, the slides aren't moving on. Can you do that? None of the slides. Yeah.
Nick, what slide can you see?
The first slide, long COVID services, Derbyshire.
Oh, no.
And also, I think if you can talk a little bit slow, as much as it's nice to hear you cover a lot of ground.
Okay, so where would you like me to start?
Well, I think if you probably need to go sort of 4 or 5 slides in at least.
Okay, so background, and I told you about case definitions, and we're accepting more than 4 weeks. Prevalence in the country, UK prevalence that I mentioned earlier, and then long COVID services. And this is where I was talking about the sort of blueprint for.
Yeah, it's still not moving. You need to sort out this slide situation. I mean, if necessary, you might ping it to us because it's not working.
I can just email it to you.
Sorry.
Okay, I'll send the slides over to everyone so then you can follow up.
Thank you.
Okay, so I was talking about the long COVID assessment service in terms of background to that, and that service started off in December 2020, and referrals are accepted from GP but also from occupational health now, and basically the referrals are only accepted once referral forms are completed, and that includes relevant blood tests and ECG and chest x-ray if there's any shortness of breath or chest pain being reported as well. And then in terms of who are prioritising, so the under 16s, pregnant patients and NHS staff, we do prioritise because they've also already been through the staff service. We've had 1,468 referrals from December 2020 to 2021, and we're still getting them at about 25 referrals a week. Since inception, so we've got 971 onward referrals, and the rest being sort of self-management or self-supported management. And the sort of places that these people go to, we've got our medical and therapy MDT, which I'll mention in a minute. Then we've got acute respiratory services, health psychology, IAPT, OT, chronic fatigue, and actually...
Yes, because it was talking before. Then all of a sudden it stopped.
Hello?
Sorry.
So all these services that we do onward referrals to, we also have one person from each of these services represent the service in our weekly MDT. So just for an understanding of sort of who's in the who we've got in terms of if anyone wants to see what our assessment service looks like, we've got 3 sort of clinical leads. We've got medical lead, myself, and we've got a service lead and an advanced therapy lead. And then we've got a mix of GPs and ACPs as well as clinic coordinators. And then therapy MDT is the people that I mentioned earlier. And then we have the medical MDT, which consists of respiratory physicians, cardiologists, rehab consultant, and occasional input from ENT and neurologists. So in terms of the process, so once the referral's been made, we have our triage nurses and band 5 nurses that review the forms, and so if anyone has sort of indicated that the symptoms are more severe, then they'll go straight to being reviewed by a GP. Otherwise, they'll go back into the waiting list, and that service seems to be working really well in terms of sort of safety netting for our patients. We then sort of do case summary records. We use System 1 and that we use, and we go through ICE and do prescribing through that as well. And in terms of onward referral, so we've got the therapy MDT that I mentioned, which happens weekly. We've got a bi-weekly medical MDT, and then everybody gets reviewed in about 4 to 6 months to make sure that they're getting all the needs met within the service, really. In terms of updates to the pathway, at the moment, the assessment service was an all-in-one service because we didn't have additional rehab services, and we kept it all in-house. However, because of the size of the service now, we've now developed 2 rehab hubs across Derbyshire. Derbyshire is quite a large county, so we've got a rehab hub in the north and one in the south, and that will be consisting of vocational rehab therapists, OT, acute respiratory services, and health psychology, and then those services, that's where we'll be going to beyond having the initial assessment by GPs in the assessment clinic. So we're just trying to streamline the service that we provide in Derbyshire. So in terms of the Derbyshire screening tool, so this is the part of the referral form that GPs fill in, and also we fill in the same form in occupational health so that we can make direct referrals to the service. And then sort of based on this, we triage in terms of waiting list priority, and anyone who is more than 3 in the red box, we see them in less than 4 weeks, and our average waiting time at the moment is 12 weeks for anyone getting an appointment. So the therapy MDT, as I mentioned, consists of the following, and it's a really good point for people who have been assessed by our GPs and need some more input from rehab specialists, and also when they may not need a direct referral into one of the services. This is a really good base to just continue managing within the service, within our assessment clinic, with some input from these guys. And then we have the medical MDT. It's quite good that we've got cardiologists and respiratory consultants on there so that we can review any chest imaging. We get to review our ECGs and any other tests that we get done within our service. Our respiratory physiotherapist does all of our 6-minute walk tests and other tests to diagnose POTS, and then sort of those patients are reviewed here before we start them on medication. So this is the image that I showed earlier of what a typical service should be looking like based on NHS England advice. And then we've got the staff service, which goes directly into the assessment clinic. So in terms of the staff service background, so that started much later. So in September 2021, refer, basically anybody who works in health and social care within the county can self-refer, or the referral can be through their line managers or occupational health. We're pretty flexible in where we get the referral from. Basically, there's got to be strong clinical indication that they've likely had COVID over 4 weeks ago, but we don't need blood tests and ECGs and x-rays to be done before that referral is made. Where once they're initially reviewed in our service, it looks like it is likely that they may need ongoing support and may need referral into the assessment clinic, then we write to GPs asking for the relevant blood tests and ECG and x-ray and things that they would need for the assessment clinic. And while they're on that waiting list, they get support through the long COVID staff service. So it's now turning into a more seamless overall experience for patients living in Derbyshire. So since September 2021, we get about 10 referrals a week, and we are able to make contact with them in the first week of them referring in. And most people go on to have some form of input. Only about 10% say self-referral help is sufficient for them. And then in terms of where they go on from there, we send them direct referral to the therapy MDT where they need ongoing management. And then essentially they're plugged into the assessment clinic services that way. So in terms of the staff service, the offerings we offer through occupational health, because although it's a joined up care initiative, it's based within occupational health service at UHDB. Our occupational health department, I should say, covers all NHS institutions within our county. And in terms of management offerings, so we support arranging investigations that I mentioned earlier. I'll show you a referral form that we use. We do desk clinic rehabilitation. So it's fatigue management, sort of support with breathlessness, improving physical activity. So we've got occupational therapists, we've got a clinical nurse specialist on the team who's a cardio rehabilitation nurse, and we all work together to facilitate sort of the physical rehab aspect of this. In terms of mental health support, we've got counselling, direct referral into Trent PTS, which is our local IAP service. We've got a 4-week psychoeducational course called Coping with COVID, and then we've got peer support, self-help, and sort of other ways of staff engagement like Facebook and Facebook Lives that we do to keep staff engaged with the service. We also signpost where that's suitable. We prescribe where indicated. So because I've got this dual hat with the staff service and the long COVID assessment clinic, if they are also a patient in Derbyshire, then I'm able to arrange prescriptions for them to get things like bisoprolol once we're talking about POTS, once we're talking about other conditions where medication may be indicated. So, for example, we do a lot of reviews of people with migraines, and we have clinicians within our service who can help in terms of prescribing for that. We, through the staff service, we have advice leaflets for families, advice leaflets to managers and colleagues, because as has been mentioned by Joe earlier, a lot of difficulties with these, with our staff are related to how the people around them lack understanding of what they're going through. And we try to support them that way.
We need to sort of wrap this up pretty soon.
Yeah.
Sorry, thanks.
That's the end, don't worry. And then occupational health advice in general in terms of returning to work. So this is what a form would look like. I just wanted to show you what blood tests we request. And then, as I said, in terms of staff engagement, we do Facebook groups and peer support weekly service. It's happened every Tuesday morning. We run a peer support group, and that seems to get about 20 to 30 people on there, and it seems to be a popular service. So in terms of the future, so we're part of Stimulate ICP. So we're starting, our research hub goes live from April 2022. We've got the rehab hubs that I mentioned earlier. There's other research teams sort of participating in the services we provide. And we've got a Live Well with COVID app coming on. I don't know if anyone else is aware of this, but it's a really good service where not only sort of self-help guidance and things, but also it allows us to track through remote digital monitoring, so people can input their data onto the service, and we can track them and see how they're coping with any sort of management advice that we provide. And really, and as I mentioned, we do prescribing, and these are kind of the things that we are looking into. End of show. Sorry for technical.
No, that was brilliant. I mean, it's a game changer, your service. I wish everyone had that. So I think people really want to see some of the detail in terms of blood tests, and certainly, we think what you're doing is fantastic. And I know you had to rush it, and I'm sorry for being a bit harsh.
No.
It's really good what you're doing. I mean, there's a few comments you might want to look at. Is this just one big research project? No, I'm sure you're coming from a much broader service perspective than that. But I do look at some of the questions. But we would like to see this obviously across England. We hoped there would be that pathway that was produced in London that would go across NHS England. We've yet to see that publicly, but so we are chasing on that. But we are on a tour of the UK. It's quite nice to see England doing well on this, but there's good progress happening elsewhere. So I'm going to hand over to Wales. Hopefully, Paul, you're ready for this, and then move to Sarah and back to Ewan. So, Paul, I can do your slides if necessary, but hopefully you can come off mute and video, and over to you. And I think there's a biography from you in the sort of invite for today. But thank you, Paul. Let's hear how long COVID has been dealt with in terms of return to work in Wales. Thank you, and that your screen sharing is working.
Great, that's good to hear. It's a little bit disconcerting because I'm used to using Teams. So let's have a look. Slideshow from the beginning. Can you all see that?
Yeah,
great.
Well done.
Thank you, Nick. Good afternoon, everybody. My name's Paul Dunning. I'm the Professional Head of Staff Health and Wellbeing in Swansea Bay University Health Board. So we serve population across Neath, Port Talbot, Swansea, for anybody who knows that kind of southwesterly part of Wales. The Health Board has 12,500 staff. I'm actually here today in place of Ruth Crowder, who's the Chief AHP Officer for Welsh Government. So let's make a start. So the question posed from today's webinar is what works from, well, basically, long COVID, what works to help people get back to work? So I thought I would in the first two slides, try and answer that question and give a little bit more detail around some of the work that's happening, particularly in occupational health across Wales. So from speaking to colleagues and from our experience, we are seeing a primary care-based model, so with GP as the kind of case manager, supporting people with long COVID across the spectrum of the illness is probably the model that Welsh Government have adopted, and the model that I think seems to be demonstrating some efficacy. So GPs are responsible for getting all the secondary care tests, making sure that everything is governed sort of centrally from a primary care perspective. As other colleagues have said, we're working very much in a self-management approach, looking at individuals' functioning abilities and then helping them to use self-management to be able to manage their symptoms with referrals to secondary care assessments when required. Occupational health has grown a service for staff alongside the community service, the service that Fauzia was describing. So we've also got a community service that's headed up by therapists that provides support for all patients across the patch. Obviously within occupational health in the NHS, we're only supporting our own staff at the moment with long COVID. There's another service in work support that is available for non-health board staff. And again, that's a very much kind of AHP delivered program that helps people to self-manage physical and mental health problems related to long COVID. And the AHPs are using the AHP Health and Work Report to provide recommendations and advice to line managers to help support a return to work or to sustain a placement in work. If I move on to the next slide, as I've said, we've got quite a robust community-based long COVID service, which supports people with some of the respiratory problems. The occupational health service has tended to be focused more on the psychosocial problems related to long COVID. Great to hear HR colleagues talking about the need for a systems-wide approach. So certainly our experience is that a supportive line manager who keeps in contact regularly, who helps the person to be in contact with the organisation as much as possible, is really supportive, as is really supportive HR and policies that in Wales, as I'm sure the same in England, has allowed NHS staff to have their full-time sick pay extended. I know that that ends in Wales in April, and there's a degree of anxiety around how people who are still off work sick and not able to work might be supported into the future. And that's an ongoing dilemma. And there's also a Welsh Government recovery app, which we encourage people who've got long COVID to access, and that's got a breadth of signposting resource and other resources that people can use to help with their self-management. So I asked a couple of the occupational health team what's particularly been helpful from a management referral perspective. So some of the advice and some of the recommendations that the doctors have been giving, no surprise, a lot of talk about extended phased return, so up to 6 months in some cases, to help people manage their symptoms as they slowly progress back to work. I won't go through everything on the slide, but you can see there's a lot around flexible working, helping people to manage commutes when they've had to perhaps historically work in the workplace. Lots of self-management advice, particularly around fatigue management and pacing. And again, the importance of line managers keeping in touch with staff when they're off sick. I'll talk a little bit about the Swansea Bay Occupational Health Long COVID Clinic. So this was established back in November 2020 by a Band 7 occupational therapist who had a particular interest in long COVID. We've had 141 staff supported to date. The referrals come from the Occupational Health Multidisciplinary Team, so anybody in the team can signpost to the service. Current wait is 18 days, and the OT undertakes a virtual initial assessment and then provides up to 2 or 3 sessions of self-management while signposting to any of the other services that the person isn't plugged into. Main presenting symptoms, not surprisingly, shortage of breath, cognitive difficulties around concentration, memory, often known as brain fog, anxiety and joint pain. So you can see some of the interventions across the self-management spectrum that are supported. Again, I won't go into those in any detail. And interestingly, along with supporting our own staff, we know from some of the data that the community-based long COVID clinic is supporting or rather 30% of their patients are NHS staff. So, you know, a third of the community team are actually providing support for our own staff. Across Wales, we're using the EQ5D, which is a measurement of function across 5 domains. And the OT has undertaken an initial evaluation of small number of pre and post EQ5D outcomes. So I think this is, we've had 29 data sets complete, and you can see that there are reductions in each of the domains across mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. It's quite a blunt tool. It's not hugely sensitive, but this is a kind of initial, I suppose, overview of some of the positive changes that we're seeing in terms of changes of improvements in function and reductions in some related symptoms. For anyone who's not familiar with the EQ5D, there's a visual analog score at the end. So you score yourself between 0 and 100, where 0 is the worst health you can imagine and 100 is the best. So again, you can see kind of improvements in pre and post visual analog scores in terms of people who've been through the occupational health long COVID support clinic. We also use the brief fatigue inventory. So again, not huge changes, but changes in terms of people reporting reductions in fatigue pre and post intervention. And then this is interesting, I thought, just in terms of the number of people and where they were when they accessed the service. So we can see that nearly half of the staff who've been through the long COVID health clinic were off work sick pre and post intervention. Just over, well, about a third were in work throughout their support. And then you can see about a quarter of people return to work during the intervention. So outcomes, we've talked a little bit about the EQ5D outcomes. The OT provides return to work advice to managers to help staff to return to work. So not surprisingly, phased return to work. Lots of reasonable adjustments, redeployment has been recommended in some cases. Suggestion of alternative roles, and there's a suggestion there around using some leave to manage an extended return to work. And some people, interestingly, HR colleagues were talking about earlier that some staff have reported an increase in confidence in being able to talk to their managers about the return to work and their symptoms and some of the challenges that they're facing with long COVID. This is just a kind of wordle of some of the words used to describe the service. So understanding, supportive and friendly probably jump out in terms of the top 3. And then this is just a couple of photos. We had a visit by the Welsh Health and Social Care Minister in February. She visited staff and service users and patients who've been using both the occupational health service and the community long COVID clinic. So the lady sitting down in the bottom left-hand corner is a radiographer who was supported by the Oc Health long COVID clinic. The Minister took a great deal of interest in hearing from people about their experience of long COVID and how services have supported them. And we're just waiting. I don't know what the situation is in other countries, but it looks like we'll hopefully have a commitment to funding NHS long COVID services for another 12 months from April the 1st. So that's a whistle-stop tour of what's happening in Wales. Thank you.
That is very nice summary. Thank you very much, Paul, and thanks for your time. I think people really appreciated that. There's some questions from Peter Noon about EQ5D, whether there's improvements over time, whether there's similarities with the Scottish service. But so do look at the comments. There's a question also from Lorna Berry about specific long COVID clinics for NHS staff and Wales. So I'll let you perhaps kind of look at those questions, Paul. Really appreciate that was a very nice, clear presentation, and hopefully you can stay perhaps for the thing at the end with Claire in terms of this variation that's occurring. It's different approaches, isn't it? So different learning, and we need to come to some consensus, obviously. But I'm going to move on to Sarah Porter. So welcome, Sarah, Chair of the some Northern Ireland group to talk about long COVID return to work support in Northern Ireland. Thanks, Sarah. Hopefully your co-host and you're going to be okay in the slides there.
Yeah.
Yeah, thanks.
Can everybody see those slides?
Yeah, that's
okay?
great.
Yeah,
Thank you.
perfect.
Yeah.
So look, I'll try just to rattle through these as quickly as possible because I know we're running a little bit behind. So I was just going to give a brief presentation really on the current sort of post-COVID services in Northern Ireland. So our services have started really a lot later than the rest of the UK. They first really started looking at commissioning the service back in June 2021, whenever the Department of Health had asked the Health and Social Care Board, so that's the organisation responsible for commissioning health services in Northern Ireland, along with the Public Health Agency, really to work with the 5 health trusts in Northern Ireland to really bring forward some proposals to support people with post-COVID symptoms. At the stage that they were looking at commissioning the service, there were about 120,000 people in Northern Ireland who had tested positive for COVID. At the minute, I think it's sitting at around 5 times that, at about 670,000, and our infection rates really have been higher than the rest of the UK for quite some months now and really remain at that level. So in terms of the commissioning of the service, really the proposal that was sent to the Department of Health had 6 separate strands, which I'll not go through in detail. They're on the slide if anybody wants to refer to them, but essentially strand 1 is the area that I'm going to focus on, which is the post-COVID-19 assessment service clinic, which is supposed to be really a one-stop MDT-based assessment service. It's been operational in most of the trust areas since November 2021. I think maybe 1 or 2 of the trust areas started in December, but it's based on that, obviously relatively recently, just operational. So one of the difficulties really has been that obviously the service started end of last year, but funding has only been in place really until the end of March, so a couple of weeks' time. And I think that has led to quite significant difficulties in terms of recruitment of staff to work in those services due to uncertainty, obviously relating to those job roles and how long they might exist for. And again, there is some regional variation in funding between the trusts. There's 5 health trusts in Northern Ireland. The little sort of icon at the top right of the slide shows the sort of the margins of those. The Belfast Trust looks like the smallest area on that map, but obviously has the highest population. And then some of the ones that covers larger areas are more rural, so would have smaller populations. But the individual trusts probably have sort of roughly equivalent patient numbers in them. So the initial proposal really for the strand 1, which is the post-COVID assessment service, was very much based on the Wales model. So it's quite good this presentation has followed on from Paul's, because quite a lot of what he has said will also be applicable to the Northern Ireland services. So initially it started off on that model with a telephone triage, really to a member of the team to have a discussion with the patient around their symptoms. It quickly became apparent that that was taking really too much time. So it changed to paper triage within a few weeks of service development. And following the telephone triage, then essentially individuals were allocated to one professional within the team for further assessment. At this time, the service commissioned is purely a single assessment and then onward referral to other services. There's no funding to review patients to see how they're getting on. Essentially, it is just a single assessment and then either self-management advice or referral back to the GP for further investigations, which is obviously a bit different to some of the other regions. Assessment's fairly standardised based on the Yorkshire assessment scale. And the other thing I suppose to note is that there is quite a bit of variation between the trusts in terms of what they're able to offer. Some of that I think is due to recruitment difficulties in terms of I think a few of the trusts have had difficulties recruiting a doctor to join the service, which I think again goes back to the difficulty relating to funding and timelines and just general staff and skills shortages. One of the trusts has a doctor in post for 1 day a week who is involved with triage and with multidisciplinary meetings. I think another trust has a doctor for 1 session or a half day a week who primarily is involved with multidisciplinary discussions, but I think the other trusts don't have any medical cover at the minute. So as I said, it's the aim really of the service is one-stop assessment service for patients referred by primary or secondary care. Team composition, OTs, physios, nurses, as I say, doctors in some areas. Again, some trusts have a psychologist who primarily attends the MDT meetings, and then some administrative support. There is an expectation that really the majority of tests need to have been completed prior to referral in order to exclude other causes for symptoms, which is in line really with the NICE definitions for the conditions. And the other thing the service makes quite clear is that it is not expected to provide an automatic medical assessment or examination. So just in terms of the sort of the need to have investigations on other conditions excluded before referring to the service, I won't go through this slide in great detail, but it's really just to give a sort of a taster of the waiting list in Northern Ireland at the minute. So these are waiting times in weeks. Any of the figures in brackets relate to urgent rather than routine referrals where those are available. Department of Health, I made inquiries about the waiting time for the long COVID clinic, but they say they're not keeping that data. They wouldn't really give a reason for that. I'm not sure if it's just because the service has been so recently established or whether they don't plan to gather any data, but essentially at the minute it's unclear how long patients being referred and are going to be waiting for that assessment. So as you'll see from the table, I mean, waiting times are pretty dire. They're measured in weeks, but they probably could equally be measured in months or years based on the number of weeks that people are waiting for. Really, these are the relevant specialties that I've picked out, which patients with post-COVID syndrome may need input from. So there's a real issue with getting investigations done, and I suppose with onward referral following the one-stop assessment if input from other specialties is ultimately required. So in terms of referral pathways, these were regionally agreed and have been directed by the Department of Health. So the individual trusts aren't able to change the referral pathway into their service. Essentially at the minute it's by electronic referral from a patient's GP, and then also referral from secondary services. So by secondary services, they mean essentially individuals who had been referred directly to other services prior to the post-COVID service being established. Essentially these services then are now referring back into the specific post-COVID service for those patients to whom that relates. So in terms of referral criteria, basically 16 years and older, they only are accepting referrals for people who have had symptoms for longer than 12 weeks at the point of referral, which obviously is different to some of the other regions in the UK. They also accept referrals from people who have been hospitalised with COVID-19 but haven't been referred on following that hospitalisation for other outpatient review. And again, equally open to people who weren't hospitalised. In line with the NICE definition, obviously don't require a positive COVID test for referral to be accepted. It can be accepted based just purely on a clinical diagnosis of the pertinent symptoms. And again, just there needs to be investigation and exclusion of other potential causes of symptoms by the person's GP. So in terms of service provision, this is data from one of the trust areas, South Eastern Trust. So in terms of the source of their referrals back in December, majority were coming from GPs, a smaller number, 13% from secondary services. Paper triage being conducted and then allocated to an appropriate professional within the multidisciplinary team for further assessment if needed, or referred back to the GP for further investigations, or directed essentially to self-management resources. In terms of self-management, really it's the use of the COVID recovery apps as the mainstay of that at the minute. In terms of the assessment that's conducted, really it's a review of history, pre-existing conditions, any regular medications, impact assessment of their current employment status. Again, like Wales, using the UQ5D tool, which is obviously a validated instrument for evaluating quality of life, and really looks at one question for each of the areas listed. So mobility, self-care, normal activities, pain and anxiety and impact on mood. Also the use of the COVID-19 Yorkshire rehabilitation tool, a speech and language screening assessment in terms of any speech, swallowing, communication issues, and then a dietetic screening tool So that comprises the sort of the full holistic assessment that's being done. In terms of assessment outcomes, so three main outcomes: onward referral to services to assist with symptom management, onward referral to services for further assessments or intervention, and then the remaining group would just be discharged with signposting advice and self-management tools. At the minute, they're using the Wales COVID recovery app. I'm not sure if there's any Northern Ireland specific app in the pipeline. One of the local charities, which is Northern Ireland Chest, Heart and Stroke, has been running a COVID rehab program really from the start of the pandemic. So that's available obviously to people to self-refer into as well. And it has a sort of an ongoing Zoom-based sort of patient support group that a lot of people have found to be quite helpful. So in terms of service outcomes to date, really the only referral pathways in place at the minute are for pulmonary rehab condition management program, which is essentially a 12-week program. Some of it's group-based, some of it's individual, provides some interventions like physio, OT input, some low-level CBT, those sorts of strategies, but that's a time limited to 12 weeks. Psychology input, dietitians, community OT, and then back to the voluntary sector. Some additional referral pathways in place for certain individuals who require them, so spirometry, speech and language, and then the pain service. At the minute, in terms of outcome data, all that's being collected really is subjective data based on patient experience. So I'll not go through the questions, but those essentially are the questions that are being used at the minute in terms of patient experience. It's a shame really there's no outcome measure at the minute being collected relating to return to work, although it is acknowledged obviously that most people being referred to the service are of working age, but I think it would be a really useful outcome measure following their assessment to gather some information about their status in terms of work or intentions relating to work, to try to gather that data really from the outset. I'm not going to go through the slide in detail, it's really just for interest, but I suppose it's a comparison with the sort of the current offering and what NICE has stipulated really as should be the minimum requirements. So there's quite a few, don't want to be negative and call them deficiencies, but there's quite a few areas of the current service that really don't meet the NICE guidelines in terms of accepting referrals 4 weeks after the start of the illness. Equity of access. I mean, NICE say that really there should be a proactive case finding approach to try to find people who are less likely to access healthcare. However, at the minute, obviously the service is GP or secondary care referral only. There's major difficulties in Northern Ireland, like the rest of the UK, in terms of GP access, and I suppose particularly for people who may have already returned to work or are struggling with a return to work, for those individuals to access input from a GP is difficult or impossible. So it would be really nice, I think, if we could have a direct pathway for OH referrals. It has been explored by Nick and myself, but the Department of Health have been quite rigid in their view that the services for GP referrals only at this stage. Whether that will change moving forward, I suppose we don't know, but I think the funding uncertainty is definitely a big barrier to trying to improve the service that's being offered. Again, NICE stipulate that the MDT should be led by a doctor with relevant skills and experience, again, which isn't really happening consistently, and that there should be clear pathways to ensure direct referral to appropriate specialist services. And NICE lists a number of specialist services that may well be required. So rheumatology, dermatology, ENT, infectious diseases, gastro, all those specialties. So really that doesn't exist at the minute. It's back to the GP and then back onto that huge waiting list for assessment. And again, NICE do recommend diagnostic and testing availability. So ability to refer for imaging, cardiac investigations, bloods, lab investigations, which again at the minute is back to the GP to request. But I suppose the only final point I wanted to make really is that obviously quality of data is key to commissioning appropriate post-COVID assessment services. And at the minute, certainly in Northern Ireland, the data isn't there and isn't really being gathered. And I think it would be really useful if we could start to gather the right data to commission a service that's going to meet the needs of the population. So I'm sorry if that's quite negative, but it's really a sort of a view of sort of where things are in Northern Ireland at the minute. And as I say, we have been quite far behind everybody else in the UK. So it's definitely interesting to hear how things have been elsewhere. I'll pass
Thanks.
back to you, Nick.
Yeah, thanks, Sarah. It is disappointing. I don't need, no need to apologise about being negative, because it isn't as good as the rest of the UK, and obviously there are challenges in Northern Ireland. There seem to be real health service stressors, but actually there's stress across the system across the UK, so there's no real reason for this. You've been a great champion, and there are inequalities. I can't see Ewan offering the Scottish perspective, so we might just hold for that. We can take a breather. I know it's been pretty full on sort of so far. If there's any burning questions before I hand over to Lesley, if people really, people here like Peter Noon, I can just see going on video. Any particular points that people want to raise before I hand over to Lesley, and we'll come back to you. And I know he's, grandparenting is important, isn't it? But any questions? It's been interesting in seeing the chat. We've got 186 people. These are people who I imagine are either health professionals or people who are concerned about their own situation and want to make a difference, probably related to your group, Lesley. I don't know, Lesley, you've got any comments on the chat, which is interesting. Some really rich stuff here, and Claire too.
Yeah, shall I start?
Yeah, why don't you start? Over to you. Yeah, thanks.
Given I'm in Scotland, I
can there we go. Two birds, one
stone. Ewan's piece as well.
Yeah, they're perfect. Okay, great.
So thank you, everyone, for a huge amount of really interesting information, which I'll be pouring over several chunks rather than all in one go, because I have long COVID, and I've recently celebrated my 2-year coronaversary by getting thoroughly depressed about how I'm not actually much better. So it's been a very reflective time, and it's very apt actually that we're here today, and thank you, Som, for putting this on. We had a conversation about, remember we did a summit back in March 2021, should we do some sort of catch up, and here we are doing it. It's actually helped me to be able to reflect back where we were a year ago and to see the progress that is being made. So Sarah, we know from a patient perspective that medicine is trying to catch up with this brand new set of challenges, and what we're trying to do as patients is to do what we can to kind of work alongside those of you whose jobs it is to try and find these solutions for us, to try and take care of ourselves in the way that Jo was describing in her presentation. And a lot of the emphasis is on self-management. So I think I want to give a shout out today to the patient groups that have done a tremendous amount of work to try and help ourselves, and also to work very closely where we can with the experts in the room, because we are the experts in our own experience, in our lived experience. And as such, we've been brought in from an early stage by people like the National Institute for Health Research to help evaluate propositions for research, in order that we can try and make sure that anything that is done for patients involves patients, so that there's nothing about us without us, and we end up having to go backwards to unpick things that haven't quite been designed in accordance with need. So I wanted to start by saying I like that Paul was talking about having a systemic approach in his presentation, and within the groups that I'm part of, we've got various OTs who would love to speak to you, Paul, and who you may well have come across in the past, because we're working really well for the last year or so with people like the CIPD, with SOM, with the TUC, and with anyone else who is happy to work with us, as a multidisciplinary group of occupational health professionals who can look for joined up ideas and thinking to try and help us find creative solutions that actually make a difference in practice for patients. It's been a revelation for me working with OTs and working with occupational health. It was a revelation in the early days when I joined SOM in early 2021, from my bed in my dressing gown, and thankfully they let me come back and I dressed up appropriately thereafter. I was having a meeting with Clare and Ewan and realised there was all these important medical people in the room at the same time, which was slightly disconcerting. But patients are now becoming very comfortable being around a table with the well people who are trying to help us, and trying to do what we can to provide information that will help. So my background is organisational development and change. I spent 20 years developing leaders in large bureaucratic organisations to try and become more agile and progressive. And in my latter years, I focused on equality and inclusion, and specifically gender inclusion and diversity, because we were seeing very unbalanced demographics causing gender pay gaps and lack of rounded thinking and so forth. So there was a real passion for me was in trying to encourage diversity. So from my couch, when I got COVID, I followed what was happening. I saw the emergence of long COVID as a thing and got involved in moderating a support group for people, thinking I was pretty much better, and I would help out others because with my skill set as a coach, it was something I could do. But then 3 months later relapsed, and I'm as bad now as I have been, which is quite hard to take 2 years down the line. However, we have been able to contribute despite the fact that we haven't been able to do regular jobs, and we have produced various resources and contributed to research. You can find a lot of resources that we've contributed to with other partners at our website www.longcovidwork.co.uk. We are part of Long COVID Support, which is now a charity, and trying to make the provision that we've made to our peers sustainable. So a lot of the presentations today have talks about the need for peer support, and Fauzia mentioned running a peer support group, and Lodi equally talks about the importance of having someone to talk to, whether that was a line manager or someone out of your workplace or in a medical context. And there's been a massive amount of heavy lifting being done by patient groups invisibly, supporting a lot of very, I can't think of a right word because I've got brain fog. People going through a very difficult time, and feeling we go to see our GPs and our GPs do what they can, and then we leave our GP surgery. I did last week, thinking, oh good, I've got more drugs to try, but actually feeling a bit deflated, thinking, you know, how am I going to get better? So we are very much focused on the social model of support for people with long COVID, not just the medical model. So thank you for including the patient perspective in this session today, because whilst the medical experts like yourselves are providing amazing care and improving care all the time, there's still a huge amount being done by patient groups that I'm slightly worried isn't that sustainable. And what I mean by that is that a lot of us, I think, are getting burnt out. A lot of us are relapsing. I'm just coming back from a relapse at the moment. So it was absolutely lovely today for Rachel and Joe to present all that amazing good advice about what line managers could do and how we can support line managers. It meant I didn't have to, because until we got to the point of having partnerships and working with people and getting this really fresh, really helpful research, patients were trying to kind of fill in the gaps and do our own research. And there's a lot of patient-led research that is very useful. So there were comments in the chat about, you know, could clinics also be research hubs? And again, that's the kind of creative thinking we're trying to come up with. So if we're doing one thing for one part of the process of getting someone from contracting COVID back into work, which for me is the ultimate achievement that you would want to be measuring as an outcome from any intervention, then we should really be looking at trying to join up a process from start to finish. And I wrote a blog a year ago to publicise the forthcoming summit, and I'll pop it in the chat later. But basically a year ago, a lot of people were struggling to get support. We were offering ourselves as guinea pigs, but we were excluded from studies because we didn't get tested because tests weren't available. And coming right up to date now, and Rachel's saying about the change in narrative around testing, and we seem to just be letting it kind of run riot a little bit. What that is meaning is that in the future, if people haven't been tested because tests are not available, or because there's been a decision made that we don't need to do it because it won't change clinical management, it can cause problems for people further down the line who aren't able to work, who might have to apply for ill health retirement, just purely evidencing the fact that they have had COVID. So our approach in long COVID work and long COVID support has been very much from the start of the process to the end of the process, trying to make those connections, join those dots, come up with that systemic approach, because there are so many multiple points of failure that we want people to get help to get over the first hurdle, or else there's no way they'll get back to work at the end of the process. So it's really powerful that today we've had lots of people giving different perspectives and coming with different parts of the jigsaw. And I hope that in the final session that Clare's chairing, we can maybe look at how we work together to kind of join some more of those dots, and how we can support areas like Sarah, who are maybe lagging behind a little bit, but obviously really keen to catch up. How to really promote some of the work that might be being done in Derbyshire that is really
yeah.
And what we need to do is think about how we can support each other. So patient groups are keen to.
Whoops. No, I was doing some muting there, Lesley. So no, I didn't mean to do that. I was muting someone else, I think. So Lesley, can you come off mute? Apologies. Off you go.
So sorry, Nick, as I was saying, there is a great opportunity for us all to work together, and it's slightly thrown off my train of thought. So I'm going to consult my notes again.
Sorry, yeah, go on.
No, it's absolutely fine. I probably needed to take a breath anyway because I get going, but we were talking about having a systemic approach and joining forces, and patients having to, by necessity, take a bit of a step back. And we don't. Rachel said to me earlier today, it must be really hard to pace when you're so committed, and we all find that. And the fact that we've got people now doing this work with us, for us, but including us, is just incredible. And if we can continue on that basis, that we can leave you to do a lot more heavy lifting, and we can just guide and input as we can and focus a little more on our own recovery, I think it would just be even more useful data to feed into the process as to how to get ourselves back to work. So the long COVID work group that we've been working in for the last year and a bit, as I said, are multidisciplinary. We're all living with long COVID, but we've all got professional expertise, and we're trying to use that to support people at different points in their return to work journey. Strategically, because we can't help everyone, by working with partners like yourselves. And it will be important that when people print off these great guidance notes that are coming from the CIPD and from SOM and take them into their managers or their HR departments and say, look, this is how we do this. If they have any questions, there's somewhere they can go. And so Long COVID Work has created a website, and we are trying to put all the links to anything that we're doing on that website so it can be easily found. It's www.longcovidwork.co.uk. We're also on Twitter at Long COVID Work. I'm on Twitter at Lesley Macniven, and we're pretty active because we really want people to, in the long COVID communities, to be aware that this work is happening and to make use of it and to access it. And the final thing I just wanted to say, long COVID has become the latest in a long line of marginalised groups. And when I was sat on my couch at the start of the pandemic, you could see how existing inequalities were being exacerbated, whether that was to do with gender or ethnicity or socioeconomic status. And so the landscape is such that I can see an awful lot of equality and diversity programmes coming up in the next 5 years. Far better if we can actually stop people from falling out of work in the first place. As was said by Ewan at the very start of this, being in work can help recovery. We firmly believe that working is helping our recovery. It's pacing that's the hard bit. And this is where my leadership development, organisational change perspective is very firmly focused on trying to develop much more agile approaches to how we manage the support for people with long COVID. You know, any kind of bureaucratic systems, any outdated policies that say you must get back to work full time in 4 weeks is not going to help anyone. But there are line managers out there who want to do the right thing for their workers and they value the worker. But what they are scared of is breaking the rules and doing something for someone that they're not meant to. And therefore that person ends up leaving work. So there's a lot more we could be doing, and I would love to work with anyone who has ideas as to how we do that. And I will stop there.
Thanks very much. Yeah, I mean, it's nice your perspective, Lesley. We've come a long way from the kind of real vacuum from NHS services to at least something as much as inequality, and that's, you know, that's good to see, isn't it? There has been a response, but
yeah,
you know, there's this variability that is of concern. I'm aware that Ewan's on the phone now. I'm not sure whether you want to come in, or I hand straight over to Clare, and you can jump in, talk about Scotland in terms of specific service kind of issues or variability or what's on offer. But it's fascinating, the chat. I mean, just from a personal perspective in terms of, you know, what people are saying in terms of what should happen in GPs, and you know, more opportunities for occupational services to be located there. Joe, thanks for your comment there. And there's some specific questions for clinicians in terms of what Catherine Beldo is saying. So do respond on the chat, but failing Ewan's not wanting to jump in, I might hand over to Clare Rayner, who's been a brilliant champion for long COVID issues, has got a fantastic background, which I'll put in the chat again. Sorry, Ewan.
Nick, I'll just apologise to everybody for the problems I've had this afternoon. I can speak. I think you're running out of time anyway.
Yeah, we are.
Probably. Yeah. So I can skip the Scottish thing if people wish, because I think Claire's got a lot to say. I can just say the Scottish system is pretty similar to Belgium. It's based on general practice and an increment self-management. A website, a lot of access to website. They've set up a recent website which has had 797,000 hits in about 2 months, which suggests there's a lot of interest in long COVID. But clinically, the demand doesn't seem to be very high among the clinicians I speak to, and the different health boards are doing different things, but basing it in the primary care model and specialist intervention when necessary. But I'll stop now because I think it's important, but clear.
Okay, over to you, Clare. Thanks, Ewan. And there's a question about which website, and I'll put the details of that. So over to you, Clare. Thank you.
Okay, thank you very much. That's quite a task for me to bring all these things together, but I will do my best. So thank you so much to everybody. The talks have been absolutely brilliant. And I'll say a few more thank yous at the end perhaps, but I just want to try and pull some of this together and summarise some of what we've heard and see where we go from here. So I think we've tried to give a really good view of things from a 360-degree perspective, having heard from patients, people working in the clinics, occupational health, and employers. So certainly given us a good an excellent all-round view, and I certainly can't believe how much further we are than a year ago. From my perspective, I have some additional viewpoints. I've been involved in the World Health Organization guideline development group for the rehabilitation of long COVID, so I can add a little bit about what we've done there. I'd like to add that I'm very, very concerned about the people who've been ill for a very long time but haven't had input, and there are a lot of them. So when we talk about inequalities, one of my biggest concerns is for the people who have been ill, very ill for 2 years and actually not received any assessment so far. We've got people, you know, receiving investigations 18 months down the line and finding out they've got scarring from myocarditis. So I think we've actually got to go out and look for the people at 2 years down the line, because I'm very concerned at their actual deterioration, and they're now housebound and are unable to even access services. So let's let's case find those people. What have we heard? We've heard from Ewan about the size and the nature of the problem of long COVID. The numbers are just growing. With Omicron, it's getting ever higher. We fundamentally have a condition which is an endotheliitis, impacts on the blood vessels all over the body, and therefore causes a complex multidisciplinary, multi-system problem. Reminded of the risks of worklessness in the long term. So, losing 5 to 7 years of your life on average, higher rates of suicide. We have to bear in mind that this we already know, and that there's a big fallout in work from people that are between the ages of 50 and 64 already. So we have to get on top of this. From Lode, we've heard a brilliant review of the actual pathology underlying this and the organ problems that may result, and problems such as significant platelet activation and blood clotting, even in long haulers, and significant cardiovascular problems. And he's talked to us about how multidisciplinary, one theme that's come through from absolutely everyone is we need a multidisciplinary team approach, which is easy to say, but we've had the offer there of linking up with a European-wide collaboration to look at long COVID and work. So hopefully we can connect up there. I have always said, as Lodi says, that there is something really important about the 3-month period. There's a shift then. And people who aren't better at that time tend to have extremely prolonged illness and be out of work for a long time. We have to prevent this. So we have to have early assessment or early enough assessment of the problems such that we can identify any organ damage and red flags, and that we can put symptomatic or more fundamental treatments in place to prevent progression. And actually what Fauzia didn't have time to say is that that's a key part of her system. Early assessment, ruling out red flag conditions, early treatment of organ damage, early symptomatic treatment, and early rehab. We know already in all conditions that early treatment leads to early recovery. So let's try and stop people getting to that 3-month period. There's another risk factor, very, very simple things we have to think about. If somebody has a very low lymphocyte count at the beginning of this illness, that's a real risk factor for a more severe condition. So we need to be doing simple full blood counts on all our patients. Rachel and Joe gave us a very key summary of the problems facing employers, and we need to work with them more. And I'm so delighted to work with CIPD and have them on board. Just to know that actually a key thing there is that we need to train line managers. Only 25% have had any training, not just for long COVID, in any training in managing long-term health conditions. So I think that's a key area for all of us to look at. They say that the things that work for long COVID are access to OH, individualized support in returning to work, and flexible return to work practices. So we need to look at that. They brought out that a long phased return is necessary, and I would agree that this is one of the key things. You need a prolonged, flexible, individualized phased return with long COVID. It's the same for other conditions that we know of. The difference here is that we have such huge numbers affected. Parity and inequalities, those have come out. We need to think about those. We've heard, it's fascinating to hear the different models of input from around the country. What I would pull out as themes are, again, early assessment, ruling out the red flags, medical red flags, and getting that treatment in place early. They then need easy access to the relevant specialists who understand the condition, such as the allies that Fauzia has in her clinic. She has specialists that understand the condition. Assessment needs to be face-to-face. I'm sorry, some things need to be done face-to-face. And listening to all the patients I've come across, and I'm also involved in a huge research study and talk directly to patients all over the country. What works for them is one face-to-face assessment, more if necessary, but certainly an early initial face-to-face one to have certain things done. The other thing that everybody says helps is peer support. And that can take different forms, but the patients say that really helps. And we've had some mentions of that. And again, Fauzia has told me about her clinic where she has learned so much from sitting in the peer support groups initially. And that's what first alerted her to some of the real physical concerns and then to deal with them. So I think that's my summary of what we've covered. I think we need to try and get parity of services around the country. It doesn't have to be expensive. The Fit for Work services model and the Healthy Working UK project a few years ago cost £10 a head, and it included some really good support services like financial support. Where do we take this from here? I think hopefully I've summarised some of that. What I'd like to see is really continuing working together with people like Sam, who have been so fantastic in raising these issues and educating out really to so many people. I think the patients really know what they need and what they want. And as Lesley says, nothing for us without us. I think the connections with the CIPD need to continue, and if we can work with you better, that would be fantastic. I perhaps better stop there. Nick, have you got anything to add, or anybody else?
Well, I'd be interested to hear from others. I suppose from our perspective, we're keen to see occupational health supporting NHS teams having a consistent offer across the UK to advocate, to CMOs. We did invite the chief medical officers to this last bit, but they couldn't make it. But I think they're aware and they know it's an issue they need to move on. So we will continue to advocate. And you might have noticed in Wales, we put in a question to the Parliament there in terms of long COVID return to work support. So, we are, and then we'll move on to Scotland. So I suppose, we feel it's an important issue that's not being addressed adequately or equally. And it's lovely to have this kind of mixture of health professionals and people with long COVID of that voice. But, frankly, occupational health is limited in terms of its coverage. We'd like to obviously see that increase. Actually, with CIPD, it's incredibly important, CIPD on board, and hats off to Rachel and Joe for doing the work, and that has a huge impact. And obviously the clinicians such as Fauzia and others, Sarah and Paul, kind of working on the ground. But I might shut up and in the last 10 minutes welcome people to come off mute, show your faces, and yeah, it's difficult, isn't it, when I can see Lesley saying things still needed to catch up, and what do we do for those in limbo? And we don't want people to lose their jobs. We want to support people. We don't want people early retired on pensions. We've got a pensions group tomorrow. I know that'll come up as an issue, but we don't want that to happen. It's not good for anyone. But I'll shut up, and hopefully people feel empowered to come off mute, and just people who haven't spoken before.
I could mention something about our health HR team. So basically, within our trust, HR have approached the long COVID service in preparation, in some ways, of what to do now that a lot of patients, a lot of staff are coming beyond the 1 year mark. What to do with them? Because I guess from their end, they're a little bit stuck as well, because they don't know how indefinitely they'd be paying these people, and whether they can afford to do it as a business, and so that's been quite interesting that HR are reaching out. We've advised about phased returns, and we've advised about redeployment, and actually also offering career breaks as an option, where they do have that mental stability offer of there would be work to come back to. Let me just focus on myself for a bit, where people can afford to do that. But things like that, I think, there are options. And I think HR being confident in what options they can provide staff is something that we are supporting them in. So I quite like the fact that that's happened.
Yeah, that's really great. I mean, I haven't been able to see all the questions in the chat while I've been talking, but I'd like to add that because I've seen things about, well, where can patients go to find the things they need? Actually, I was involved in doing a big study, a consensus on what should be included in the assessment. So I and other doctors produced a checklist of what should be done for everybody with long COVID. And so I'm happy to send that consensus out to people, but it's literally a checklist. These are what you need. And there are a few things that have perhaps come along lately, but most of it remains the same. And that's what people need to know about. I think those people who have been out of work for a year and 2 years, they deserve urgent attention, and they're gonna be a lot more ill, and there's a lot more things turning up, even at this late stage in those people, blood clots, all sorts of things that need dealing with. So,
Rachel, it'd be good to hear, what's the feedback been in the CIPD and for your members to that report and the work? I mean, are people, you know, is it been good?
It's been really good, especially, yeah, which I think shows that need and the desire on HR, on a lot of people in HR to do the right thing. Because when we published it, we had 4,000 downloads of the report really quickly, and sometimes we wouldn't get that in a year for a lot of our content. And then the other guide that I showed briefly on managing long-term health conditions, that received the same amount again. So they're really right up there. But I think we need to keep reinforcing it as well, which is why we've started, and we'll be releasing the actual more practical guides based on that research.
If I could add as well, Rachel, because I think this is where the partnerships worked really well, because we were able to post in our group of 50,000 members as soon as the report came out and said, look guys, you want to get a hold of this and take it to your line manager. And loads of people came back and commented. I think I passed that back to you quite quickly. This is great, this is really useful, I've passed it on already. So, you know, I think that's where the partnership working really pays dividends, because we can make sure not just that we produce this, but we get it in the right people's hands as well, and the right people are involved in the research in the first place. I just wanted to add to what Fauzia was saying as well about HR. You know, at long COVID and work, we know that it might not be possible for everyone to go back to return to work. We have to be realistic, but from an HR point of view, you have good leavers and you have people who you allow to just literally fall out of work. And there's a whole different way of managing it. And a really interesting stat that I wanted to try and squeeze in was when the military, who are trying to rehabilitate uniformed officers, did a presentation for SOM, they said 90-something% of people that they are rehabilitating, they can get back into work of some sort. And when you have that closed system where you can say to the line manager, you need to find somewhere for this person because they are still going to be employed here, it makes things an awful lot easier. So we're not saying we can get 90%, but at the moment, I think a recent stat I heard from a clinic was 40%. So there's room for improvement in if we can be a bit more flexible. But as I think somebody was saying in the chat earlier, you know, trying to find a more flexible job is incredibly difficult. So what resources are we giving people? Are we putting people in touch with the kind of employee assistance programs that we have, and that the kind of resources we offer to people who are being made redundant to try and help them pivot their career and do something different? Because I think a lot of people will choose to do something differently. And there has been a lot of people changing jobs in the pandemic, COVID or not, because it's been a time of change. So there's lots that can be done. And it's not the case we want people to be paid indefinitely. But the final point was we had a furlough scheme to protect jobs, and we paid people to stay at home. So why can't we have some sort of government-based scheme to support employers to keep jobs open for people who are sick that we expect to recover, but we can't put a time limit on it? So there's a part of this that's about galvanizing people to ask the government to provide more support for the greater good that we've all talked about today in keeping people in work.
Yeah, and compare the cost of a few investigations at an early stage to having an employee off for 1 week. It's you know, employers really need to think about that.
Absolutely.
The other thing I was going to mention from my rehab guideline development with the WHO, there are actually many specific impairments for which there are some really good inputs rehabilitation wise. So there will be a set of 11 different clinical topic areas, and we've mentioned some today, but the things really work. You know, they really help once you've ruled out the major issues. And I suppose my final comment is I really think that occupational health need to be involved in the way that Sarah and Fauzia and many, many other people have suggested on here today, that there has to at least be that close link.
And a very strong voice actually from someone about GP needs to be involved. That's very
absolutely, absolutely. Yeah. I'm sorry, I don't mean to leave out at all. I just take it for absolute granted. It's absolutely key, and I think it's absolutely key.
Any other comments either from sort of Rachel, Jo, Fauzia, Lesley, Sarah, Paul, speakers, but anyone from the audience too, as we draw this to a close?
I think it's about, in terms of long COVID services, and it is a little bit heartbreaking, some of the stories I hear about what's going on in other parts of the country. And that is because fundamentally, we all got a set amount in the pot to spend on our services, but also like it's so, I don't know if I should say this, but there is money floating about.
Yeah.
And there's lots of different things and lots of different services where you can get money through. So we've got health and wellbeing advisors on our service now, and that's through a health and wellbeing initiative that NHS England have launched. And we've been looking at different pots of money, and that's how we've been able to build our service. Our consultants are kind of getting a bit twitchy about being unpaid for the last year. So we now are putting them in, giving a job description and putting it as part of one of their SCAs or whatever.
Yeah.
And so, you know, we are starting to pay people. But I think that there are a lot of clinicians, and there are a lot of good people out there who can see the impact of long COVID on their colleagues, on their staff, on their patients, and who do want to help with the expertise that they have. And so it's about bringing the right people together. And I think the beauty of our service is that people who work in our service all want to be there and all want to do the right thing by their patients. And so, you know, it's sad that some people feel as though their service have treated them like guinea pigs or research projects and things like that. But actually we care and we genuinely care about our patients. And so, you know, I just hope it can be emulated elsewhere.
Thanks, Fauzia. Yeah, it's interesting. We had a meeting with Chris Whitty, the CMO, and this is actually about trainee places. And he said, this isn't necessarily, you know, money. The money's there. It's just about how, you know, whether you've got the capacity to do it. So the higher you go up on the kind of hierarchy of sort of power, the money just doesn't become an issue. Any other final comments?
I just want to flag one thing.
Paul. So Rachel, then Paul.
Oh, okay. Yeah. Really quickly. I just want to flag one thing, just to emphasise, and Claire mentioned this already, and just the importance of CIPD, you know, bringing together HR professionals and occupational health professionals. I mean, Nick and I have been trying to do that for some years at this level, at the national level, but even before COVID, long before COVID. And I think when the pandemic came, that working relationship became even closer, and also with other organisations as well, because we are stronger together, and especially in terms of making that impact in the workplace. And so that will definitely continue, definitely. But there is a challenge about how we cascade that down to an organisational level as well. And we knew there was a need for it before, but now with long COVID, you know, that's a really acute need that HR needs to make much more use of all that specialism that occupational health has. So we will continue with that.
Yeah, thanks, Rachel. Well said. Yeah, I think it's that cascade and making those connections locally. I think nationally we're in a good place, and it needs to be right the way across, isn't it? Paul.
Yeah, just picking up on the financial point, because one of the challenges we have in Wales is with this being fixed term funding. Hopefully we've got another round of funding for a year, but it is quite difficult to recruit a permanent workforce, and we're struggling at times to, you know, make sure that the fixed term workforce that we have can continue to deliver the work and the skills and the experience that they've built up over the last 18 months. So there is pressure on Welsh Government to fund, a permanent rehab service that would include long COVID and potentially other conditions. And then just on Rachel's point, I mean, certainly in the NHS and certainly in the service that I work in, occupational health sits in the workforce and OD sort of family. So there's very good close working between occupational health and HR and OD colleagues.
Good. I don't know who's going to be answering our parliamentary question. It might end up being you, Paul, but I know sometimes you answer the question to people you work with. But look, I mean, I think we've run out of time. It's been a really good afternoon, a very good state of play. I mean, I think there's real challenges and there's, it's frustrating and annoying and still so much to be done. But actually, there are some positives. Looking back, actually, what has been achieved and what's come together and what the advice is and how we've all got a responsibility to have those conversations, what is best practice from CIPD and others, and highlight the kind of great work of Fauzia and, get that to be longer term funding in Wales and Northern Ireland, just to get something on the books would be a good start, building on, that sort of small start right across Northern Ireland. So in a way, it's quite positive, but I would like to thank our speakers. Thank you, Lesley. Thank you, Claire, Joe, Rachel, Paul, Sarah, Fauzia, and Lode as well. Thank you for doing that research. And, we'd definitely obviously like to be part of that European research. So lots of good things, lots of things to work on, in particularly Claire and Lesley. I know you work incredibly hard and to reach out to that population of people with long COVID. So keep up the good work and stay in touch, and we will reflect on what the next steps are in the group that Ewan chairs. But thank you all, great work, and have a lovely afternoon. Enjoy the nice weather if you can, get some sun.
Great session, thank you very much.
Thanks.
Thanks everybody.
Bye.
Bye-bye. See you later.
Bye.